Insulin analogues. They are modified forms of human insulin produced by recombinant DNA technology, with altered amino acid sequences for more predictable absorption and improved pharmacokinetic properties. Classification of insulin analogues. Insulin analogues are broadly classified based on two important properties: their speed of action and their duration of effect. Based on these characteristics, insulin analogues can be divided into two major types: rapid-acting insulin analogues and long-acting basal insulin analogues. Let's start with rapid-acting insulin analogues. As the name suggests, these insulins are quickly absorbed after subcutaneous administration. As a result, they produce a rapid onset of action and are primarily used to control postprandial hyperglycemia. The second group is long-acting basal insulin analogues. These formulations are designed for slow, steady release over an extended period. This slow and steady release helps maintain basal insulin levels throughout both the day and night, closely mimicking the body's background insulin secretion. Rapid-acting insulin analogues. These insulin analogues are absorbed rapidly after subcutaneous injection and are mainly used to control postprandial hyperglycemia. Rapid-acting. Examples. The three most important examples are Lispro, Aspart, and Glulisine. Let's start with Lispro. This was the first rapid-acting analog to be introduced into clinical practice. In Lispro, the lysine and proline residues are swapped at positions B28 and B29. This structural modification reduces self-association of insulin molecules, allowing faster absorption from the injection site and a more rapid onset of action. The second example is Aspart. In this analog, proline is replaced by aspartic acid at B28. This change prevents insulin molecules from forming stable hexamers, resulting in rapid absorption. Because of its predictable pharmacokinetic profile, Aspart is widely used in insulin pumps. The third example is Glulisine. Here, asparagine is replaced at B3 and lysine at B29, producing a fast dissociation profile. As a result, Glulisine is rapidly absorbed and provides effective postprandial glucose control. Rapid-acting. Pharmacokinetics and use. The most important pharmacokinetic feature is their rapid absorption. These insulins have an onset of 10 to 20 minutes. This rapid onset closely matches the rise in blood glucose that occurs after a meal. After administration, they reach their peak effect in 1 to 3 hours. During this peak period, their glucose-lowering action is strongest, making them particularly effective at controlling postprandial hyperglycemia. Their overall duration of action is relatively short, approximately 3 to 5 hours. This short duration reduces prolonged insulin exposure and lowers the risk of late post-meal or nocturnal hypoglycemia compared with older short-acting insulins. These pharmacokinetic properties explain their clinical use. Because of their rapid onset, they are typically injected just before meals, providing insulin exactly when it is needed. They are a key component of basal-bolus insulin therapy, where rapid-acting insulin covers meals while basal insulin provides background coverage. In addition, rapid-acting insulin analogues are also used in insulin pumps because their predictable absorption and short duration allow precise adjustment of insulin delivery throughout the day. Long-acting insulin analogues. They provide slow, steady insulin release to maintain basal insulin levels throughout the day and night with minimal peak effect. Basal analogues. Examples and duration. The first example shown is insulin Glargine. It has a duration of approximately 24 hours, making it suitable for a once-daily injection in most patients. An important feature is its peakless profile, meaning it releases insulin at a relatively constant rate without a pronounced peak. This reduces fluctuations in blood glucose and lowers the risk of hypoglycemia. Next is insulin Detemir. Its duration ranges from 16 to 24 hours. A key characteristic is that it is albumin-bound, which contributes to its predictable absorption and consistent glucose-lowering effect. Some patients may require once-daily dosing, while others may need twice-daily administration depending on the duration achieved. Finally, we have insulin Degludec. It has a duration of more than 42 hours, making it an ultra-long acting basal insulin. Because of this extended duration, it can be given once daily with flexible timing, which improves convenience and adherence for many patients. Basal analogues. Clinical use. Basal analogues are usually given once daily, although some patients may require twice daily administration depending on the insulin use and the patient's glucose profile. The goal is to provide continuous insulin coverage throughout the day and night. These agents are specifically used in basal insulin regimens. It helps control fasting blood glucose levels and prevents excessive glucose production by the liver between meals. Another major advantage is that basal analogues provide stable background insulin with minimal peak effect. Unlike older insulins that may have pronounced peaks and troughs, these analogues produce a smoother insulin profile. Clinically, this reduces glucose fluctuations and lowers the risk of hypoglycemia, particularly nocturnal hypoglycemia. Basal analogues are the cornerstone of basal-bolus therapy in both type 1 and type 2 diabetes. In type 1 diabetes, they replace the body's basal insulin requirement, while in type 2 diabetes, they are commonly added when oral anti-diabetic drugs alone fail to achieve adequate glycemic control. Advantages of insulin analogues. The first advantage is predictable pharmacokinetics. Insulin analogues provide more consistent absorption and action profiles compared to human insulin. This means their onset, peak, and duration of action are more predictable, allowing clinicians to achieve better glucose control with less day-to-day variability. The second advantage is reduced hypoglycemia risk. Because many insulin analogues have smoother and more physiological action profiles, they are associated with a lower incidence of low blood sugar episodes, particularly nocturnal hypoglycemia. The third advantage is better postprandial control. Rapid-acting analogues closely match the mealtime insulin surge that occurs naturally after eating. As a result, they are more effective at controlling post-meal rises in blood glucose, reducing postprandial hyperglycemia. Finally, the physiological mimicry. One of the greatest strengths of insulin analogues is that they more closely replicate natural insulin secretion patterns of the pancreas. Rapid-acting analogues imitate meal-related insulin release, while basal analogues mimic continuous background insulin secretion. Key takeaways. First, these are recombinant insulins, meaning they are produced and modified using recombinant DNA technology. The purpose of these molecular modifications is to achieve improved pharmacokinetics, allowing insulin to act either more rapidly or more predictably than regular human insulin. Among the rapid-acting insulin analogues, remember Lispro, Aspart, and Glulisine. These agents are designed to control postprandial hyperglycemia. Their rapid absorption gives them an onset of action of about 10 to 20 minutes, making them ideal for mealtime glucose control. In contrast, the long-acting insulin analogues, Glargine, Detemir, and Degludec, provide continuous basal coverage. They have a relatively peakless profile, resulting in more stable glucose control and a lower risk of hypoglycemia. Most are suitable for once-daily dosing, improving patient convenience and adherence. Overall, insulin analogues represent a significant advancement in diabetes pharmacotherapy, providing safer and more physiological glucose control through precisely engineered molecular modifications.